based on an infective endocarditis, okay? So which of the following statements regarding right-sided cardiac valvular disease is true? What are your thoughts? So most commonly, infective endocarditis, especially from dental sources, affects the left side of the heart, and the mitral valve is the most common valve affected by infective endocarditis. If it's on the right side of the heart and it's on the tricuspid valve, the most common thing that causes that is IV drug use. Okay, so just remember that when you're looking at a left-sided versus a right-sided infective endocarditis. For which of the following patients would it be appropriate to prescribe antibiotic prophylaxis for the prevention of bacterial endocarditis? Remember, we had set criteria on who would be high risk of developing infective endocarditis. You got to know who would benefit from that prophylactic antibiotics. So high-risk procedures are anything that manipulates the gingival tissue. So A is the correct answer on this one. So the B, you might be thinking, okay, history of endocarditis, but cervical lymph node biopsy is not a high-risk procedure. Okay, so that's why that's not that's not the answer. And then an aortic bioprosthetic aortic valve undergoing cystoscopy for evaluation of hematuria. Again, low-risk procedure, not manipulating the gingival tissue. So that person would not benefit from it. And then 40-year-old woman with mitral valve prolapse and severe mitral regurgitation about to undergo root canal dental surgery. So that would be a high-risk procedure. However, she doesn't have a high-risk condition to warrant prophylactic antibiotics. Okay? Does that make sense why A is the correct answer? All right. So think about what you know about the cardiovascular system. When you think of it, you think of the adult, you think of it as the child, the adolescent, the infant. But do you ever really consider what it looks like in utero? What are some fundamental things about the cardiovascular system that we know once a baby is born? Where does oxygenation occur? In the lungs, right? Do babies breathe in the uterus? No, right? They rely on the placenta for that oxygen exchange between the mother and the baby through the placenta, right? So that placenta is the site of oxygen exchange, oxygen-carbon dioxide exchange, nutritional exchange, so that the baby can continue to develop normally and appropriately. But where does that umbilical vein go after the blood is oxygenated? Does it go into the aorta? Well, no, it actually goes up through the portal system into the inferior vena cava, and then comes back to the right side of the heart. That's the other fundamental change, is the right side of the heart we normally typically think of is just deoxygenated blood, right? It's all that return of blood from the peripheral system, and all that oxygen has been taken off, right? Well, in the baby, the right side contains oxygenated blood coming from the placenta. So if we were to have a normal circulatory system, can you imagine in this environment, there would be a lot of inefficiencies, there would be a lot of wasted effort, a lot of wasted time in trying to get oxygenated blood from the right side over to the left side. Imagine if you had to go through the lungs that are not oxygenating the blood to get to the left side of the heart. What should the baby be doing during this time in utero? Should be growing, organs should be developing, and all this kind of stuff. So if I'm wasting effort, wasting power, wasting nutritional calories on just circulating blood in an inefficient manner, does it make sense that that's going to interfere with the normal development of the baby? So because there are these inefficiencies, there are some things that are developed in the fetal heart to bypass, to make it a more efficient pump system. Okay? One of them is the foramen ovale that I have here circled. The interesting thing is that this is a one-way flapper valve that allows blood to go from the right side to the left side. Okay? But the location of it is in a perfect position that as that jet stream of blood coming back from the inferior vena cava that is now better oxygenated than what's coming down from the superior vena cava, it actually is directed straight at that one-way flapper valve. So the majority of blood that goes from the right to the left through that foramen ovale is actually oxygenated blood. There's very little deoxygenated blood going through that valve. The rest of that blood then goes into the right atria and then into the right ventricle. And you can kind of see the color in the right ventricle is purplish color because, yes, 100% of the oxygenated blood does not get access to the left side, to the left atria through that. There is some that does stay in there, but instead of it being oxygen deficient, it's just oxygen poor. So that's why it's kind of purple. But does it also make sense that whatever blood does make it into the right ventricle, that sending that to the lungs is a waste of effort? Because again, oxygenation is not going to occur in the lungs in a fetal circulation. So what ends up happening is you have this additional little bypass that's created right here called the ductus arteriosus that actually bridges the pulmonary artery to the aorta. And now you get another bypass of that blood to try to get that oxygenated blood to the peripheral tissue. And if you look at where that ductus arteriosus is, you see that higher oxygen content blood is going up to the upper extremities and to the head because you have that aortic arch first, then that oxygen poor or oxygen, less oxygen containing blood kind of mixes after the arch before it goes down into the lower body, into the lower extremities and everything like that. Okay, so that's kind of a unique thing that happens with fetal circulation that you don't see or shouldn't see once that baby is born. So when you have a problem where these bypasses that naturally are there, if they don't go away after the baby is born, or maybe there's a change or there's an alteration in how the heart is formed, then that leads to congenital heart disease. So any deviation from the normal arrangement, the normal flow of blood is considered congenital heart disease. And when you think about congenital diseases, and this includes like malformed limbs, this includes like cleft palates, all the other congenital diseases that you can think of, congenital heart disease is actually the most common congenital disease you're going to see. And of the congenital heart diseases, the ventricular septal defect is the most common. Okay. But does it also make sense that if we have a premature baby, so a baby born less than 37 weeks, does it make sense that they're going to be at a higher risk of congenital heart disease? Because think about it. If the baby was born early, there was probably some stressor that triggered that premature labor. And part of that stressor could be the organs weren't formed right? That's one way. Or some of the changes that occur naturally don't occur because that baby is not developed enough for those changes to occur to cause like the ductus arteriosus closing and those types of things. So the stressors can trigger abnormal growth and all that can cause this, but then also that premature birth then can lead to the continuation of those bypass things. And the reason, let me go back to that last line, the reason that we have to learn about this in PA school is many of the congenital heart diseases are not going to be detected in the newborn nursery. They are going to be detected 2 days after they're discharged, 1 week, 2 weeks after they're discharged, 1 month after they're discharged. And guess who they're going to be following up with when that happens? Their PCM. That's what you guys are doing, right? So this is why you all need to learn congenital heart disease. Even though you may not be working inpatient pediatrics, you may not be on the OB team delivering these babies, you need to know this because they're going to come and see you, and you're going to be the one making the diagnosis. Okay. So congenital heart disease, why does it happen? Well, there's a couple of reasons it could happen. It could be that there's just something went wrong in the development of the organ itself. Okay. So instead of twisting right, it went left, or vice versa. So you end up having things flipped, or the normal arrangement isn't there. So it could just be a random kind of thing that happens. It could also be genetics, which it could be inherited, meaning everybody in the family has this congenital disease, or during the gene random assortment that you get with the gamete cells, maybe there's a mutation, a spontaneous mutation that develops that actually hinders and harms the development of a baby that is conceived with that mutation. Okay, so you can get these spontaneous mutations. The next thing is, okay, we talked about nature nurture. Well, what happens if the mother is exposed to something that triggers the congenital heart disease to develop? And you think about it, okay, we think of fetal alcohol syndrome, and that's, yes, that, they're drinking excessive amounts of a toxin that is teratogenic, so it can interfere with development. But things like rubella, which the vaccines and MMR is becoming tightly scrutinized right now. We're seeing measles outbreaks here in Texas because of lack of vaccination with MMR. But part of that MMR shot is rubella, and if a mother were exposed to rubella and does not have that immunity to rubella, and they catch that, it can actually lead to rubella syndrome, which includes microcephaly, which I don't know if you all remember the Zika virus. That was one of the big things that everybody was scared of, right? But it also can cause a patent ductus arteriosus, so a congenital heart disease. That's part of the syndrome of maternal rubella, which that's one of the reasons we test at the newborn, or the prenatal, the first prenatal appointment. We actually will test for antibodies to rubella to make sure the mother is protected if they were to be exposed to rubella in the first place. And then the other reason that this might happen is, let's say there is some kind of maternal factor that creates an environment that the baby can't grow normally in. And this is things like diabetes. This is things like thyroid disorders or high blood pressure, where maybe the blood flow to the placenta is impacted, and now the baby's not getting the nutritional and the oxygen requirements to develop normally in utero. So 4 main reasons and 4 main causes of how these congenital abnormalities can develop. Other kind of considerations that you need to think about when it comes to congenital heart diseases is the presence of a congenital heart disease will put this person at a higher risk of infective endocarditis. We talked about that being one of the things that puts them at high risk of developing the condition if they were to undergo a high-risk procedure. But does it also make sense that if there is a alteration of the normal anatomy of the heart, that alteration could impact the normal conductive pathway, which then leads to this patient being higher risk of developing abnormal rhythm or an arrhythmia, because that conductive pathway is distorted. Or now you got the flow going in one way when it should be going the other. right? And then we'll talk about Eisenmenger syndrome, but this can lead to pulmonary hypertension. And then if they have a cyanotic congenital heart lesion, then it can lead to further problems down the road for them. Now, about only 28 weeks after conception, the rapid dividing of the cells starts to exceed the normal diffusion of oxygen, and the fetus has to develop its cardiovascular system to make an efficient pump to bring oxygen and nutrients to the cells and to the organs that are developing at that point. So at about 28 weeks, this is what the heart looks like. Okay? You can see the labels of what they're called, and then on the far right, it shows you what they will become. And that YouTube link there can kind of shows you kind of how this folding and everything like that. Because does this tube look like the heart that you think about, the arrangement of the heart that you think about? The answer is no, right? But does the arrangement make sense, though, where the right atrium is actually the most inferior part, and the left atria is kind of also inferior? Are the atria normally inferior in the heart? Well, no, they're actually the superior aspect, right? And there's some kind of, there's a folding and twisting change that occurs to make the heart of what we think. That arrangement and the anatomical arrangement, how those things interact and all those types of things. So it's kind of interesting to see how this primitive heart will change into the heart that we think of. But part of the problem, though, too, is, okay, you have a hollow tube. Can we have a hollow tube for a heart once you're born? And the answer is no, because if you have a hollow tube, there's no left or right. Then there is no control of the direction of blood flow, of deoxygenated blood and oxygenated blood, to direct it to go the way it should. So part of the folding process and the development of the organ and all that kind of stuff is you have to develop some kind of divider to separate the two sides. Okay? So you start to see this happen early on. But remember what we talked about when we talked about the foraminal valley. We talked about how we want to get that oxygenated blood coming up from the placenta through the umbilical vein. We want to get that directly to the left side of the heart to kind of bypass the lungs, right? So we got to create a one-way flapper valve. And the way this happens, you can see here, is, okay, the hole between, or the space between the right and the left atria is called the ostium primum. Ostium meaning hole, primum being one. Well, the septum primum, so the first septum, starts to develop and goes down to form that divide between the left and the right side. But we want that one-way flapper valve to be there. We want to have that bypass. So what ends up happening is you get a little resorption of the cells of the septum primum, and it now becomes the ostium secundum, or the second hole. Okay? Well, we can't just have that hole existing in and of itself, because when you're born, you want to not have that hole there. You don't want that right to left shunt to be there, because you're going to now mix deoxygenated blood with oxygenated blood. So we can't have this persistent hole. So what ends up happening is now you have the septum secundum, so the second septum, start to grow down and develop, and it kind of overlaps this ostium in a way where now you have some coverage. But it now creates a one-way flapper valve. That septum primum cannot move towards the right atria. It can only move towards the left atria. So it's a one-way door. So it allows that blood in utero to go from the right to the left when the pressure on the right side is higher than it is on the left side. Okay? But now the baby's born. Baby starts to breathe oxygen. The oxygen exchange is now not at the placenta, it's now in the lungs. And now that pressure, that intrathoracic pressure goes down because now those lungs are fully expanded and they're not collapsed. And now you start to have the pressure on the left side increases, and it's going to close that foraminal-valley. And then that ductus arteriosus is going to close off as well. So now you don't have these bypasses that you needed in utero. Those bypasses should go away. And now you should have that distinction of right-sided is deoxygenated blood, it gets sent to the lungs and becomes oxygenated, and then it comes back to the left side as oxygenated blood to be circulated to the peripheral arterial system, to other organs and everything like that, to meet your metabolic needs in demand. But not everybody, not every baby has this normal process occur. And that leads to the development of congenital heart diseases, which could be classified as acyanotic or cyanotic. Those are the two kind of big umbrella descriptors of congenital heart diseases. And you can kind of see the list of what we are required to talk about according to the advanced blueprint, in which category they fall under. Okay. So we're going to first start talking about the acyanotic lesions, and we're going to talk about the atrial septal defect first, okay? So we talked about how that atrial septum develops with the septum primum, septum secundum, the ostium primum, the ostium secundum. We talked about that. But what happens if that the cells are excessively reabsorbed? So now the hole is, the ostium secundum is much bigger than it should be. Or maybe that covering down doesn't occur, and now you have this persistent hole or this persistent pathway of left atria, right atria. And you can see this happens in about 13% of congenital heart disease patients, 1 in every 1,500 births. Okay. Parkland Hospital in Dallas is considered one of the most, or one of the busiest labor and delivery. They deliver about 12 to 14,000 babies a year there alone. And you can see 1 in 1,500 births have it. You can assume, probably 1 in 8, they have about 8 or 9 babies a year born with an atrial septal defect there alone. So what ends up happening with an atrial septal defect? Well, ultimately, you're having oxygenated blood moving from the left atria as it comes back from the pulmonary arteries, the pulmonary veins, and gets sent over to the right atria because that pressure on the left side is higher than it is on the right side. So the flow goes from high pressure to low pressure, so that flow goes from the left atria to the right atria. Okay. But the problem with this is, okay, and the reason it's acyanotic is, okay, you're still having oxygenated blood leaving the left side of the heart, so it doesn't look like you are having hypoxia. But the problem is you're having all this extra volume going to the right side of the heart that shouldn't be there. Because not only are you having this shunting of left to right, then you also are having all that venous return of all that blood that happened to get through to the extremities and all the other organs and everything like that. That's all coming back up to the right atria as well. And that increases volume on the right side, which increasing in volume, it means we increase pressures on the right side, which then leads to higher pressures in the pulmonary system as well. And that can lead to complications from that. How much blood goes from the left to the right? Well, it really kind of depends on a couple of things. Well, how big is that size of the defect? Is it just this little tiny pinhole thing, or is it a, half a centimeter hole? That's going to influence how much can cross over. What's the pressure gradient? If the pressure is 10 millimeters of mercury on the left and 1 on the right, a lot more blood can shunt over before you kind of get a equilibrium between the left and the right. Versus you have 10 on the left and 9 on the right. Now you only have 1 millimeter of mercury difference, so that flow from high pressure to low pressure is quickly going to diminish. Okay. And then the other thing is there any kind of resistance to that flow? So those are kind of the 3 factors that can influence this shunt from left to right. So most of the time, small ASDs do not cause any problems. You're not going to have any symptoms related to this. The shunting of blood is there, but it's not an excessive amount necessarily. So they won't know, or they won't have any symptoms to bring to your attention that something is wrong. Okay? The problem is, though, that if they are allowed to exist and live with this, that's going to add stress to the heart. And when your body is exposed to stress, it compensates. So now they become 40. Now they've had 40 years of stress on the heart and compensation and changes and all that kind of stuff. Now they could start to have symptoms related to it. If they have a large ASD and now you're having a large volume of blood shunting from the left to the right, these kiddos are going to present pretty quickly with heart failure kind of symptoms, because now you're having all that extra volume, you're having a volume overload that then leads to right-sided heart failure, leading to the symptoms that we normally associate with heart failure, okay? Other things that you might notice on your physical exam, so there may be a right ventricular heave because that right ventricle is having to squeeze harder because of all that extra volume and pressure that exists because of that left to right shunt. But kind of the pathognomonic kind of thing that you're going to see that all of your standardized tests are going to put down when they want you to pick ASD as the answer is this fixed split S2. Okay? It's not a true heart murmur. Remember we talked about physiologic splitting of the S2, right? A fixed split does not change based on inhalation or exhalation or that respiratory cycle. It is always split. You always hear that at the end. Okay? It's not really a true murmur, but what's happening is because of all that extra volume and pressure on the right-hand side, it's causing that pulmonary artery or that pulmonary vein, valve to stay open longer to get that volume and that pressure out of the heart. Okay, so fixed split S2 is kind of the classic board question for ASD. Now you may see, because of all this extra volume flowing across the pulmonic valve or the tricuspid valve, you may hear some flow murmurs associated with that. So you'd be looking at either a mid-systolic ejection murmur if you're listening in the pulmonic auscultation site, or you may hear a mid-diastolic murmur if you're listening over the tricuspid auscultation site. Okay? But those are not true murmurs. There's not a true valvular disease. It's just that you have all this extra volume flowing across those valves. EKG may be normal. There may be some right axis deviation or right ventricular hypertrophy because of all that extra volume and pressure, and if this is something that the child has been dealing with for a period of time and you get that compensatory change developing. So you may get those things. You may get some conduction changes or whatever on EKG, like an incomplete right bundle branch block. And then if they're older, because of all that extra stress from the higher volume, higher pressures in the atria, you may start to stretch the conductive pathways, and then you may start to see arrhythmias develop. Chest x-ray may be completely normal. If you have a large ASD, you may see the signs and evidence of like pulmonary congestion and those types of things, but they typically may not be diagnostic in your patients with ASDs. But your test of choice is going to be your echocardiogram because you're going to be able to visualize that atrial defect. You're also going to be able to visualize the degree or get an estimation of the degree of that shunting from the left to the right. Because you're going to, when you put Doppler on it, you're going to see that blood flowing across and you can kind of measure how much is going from the left to the right as well. So echo is going to be your test of choice in a patient with an ASD. So now that we've diagnosed it, and we know what we're looking for in order to diagnose it, how do we treat it? Well, the good thing is, if you have a small ASD, meaning less than 6 millimeters, these tend to close spontaneously without us having to do anything for it. Okay? The body just needed maybe a little extra time to make up for that. If you have a large one or a persistent one, then that is a problem because they can have a lot more symptoms related to it or a lot of complications that will develop because of it. And typically we need to do surgery for those folks. So anything like 8 millimeters or greater is less likely to close spontaneously, and we're going to need to do an additional procedure to fix it. And it used to be our only option was to do an open heart surgery where we open up the atria and then we put a patch or we sutured the hole closed like you see here. But fortunately, with our less invasive type of procedures developing, we now have the ability to thread catheters into the heart, and then I can put a patch on either side of that atrial septal defect, deploy that patch, and then it gets secured to the walls, and then that hole is now closed. So imagine the recovery time, imagine the pain and all the other complications that develop, or the difference between those in somebody who gets a open heart surgery that requires bypass versus just doing one of these less invasive procedures where I'm just threading catheters into the heart and deploying a mesh-like structure. Okay? Before we move on from atrial septal defect, I did want to talk about patent foramen ovale and talk about how this, although it works kind of similar to a atrial septal defect, this is not a true congenital heart disease. Okay, the foramen ovale we said was good, and we needed it for our fetal circulation. But when we're born, we don't want it to be there because we don't want right-sided blood mixing with left-sided blood. But and normally what happens is, as that pressure, or as you take that first breath in, that pressure rapidly increases on the left side compared to the right. And now that one-way flapper valve that we had is forced to remain shut because that pressure on the left keeps that shut. And it should then scar up and heal and permanently close. But it doesn't happen to everybody. And so what ends up happening is that one-way flapper valve is still there, and most of the time you have no problems because that higher pressure on the left keeps that valve closed. But let's say something were to happen where now the right side of the atria gets a higher pressure than the left side of the atria. That higher pressure on the right is going to open that flapper valve, and now right-sided contents will get sent over to the left. And the problem, and one of the things that can cause that pressure to increase rapidly on the right compared to the left, is let's say a blood clot forms in your legs and gets sent to the right side of the heart. That opens, that increases the pressure in the right atria. That then opens the flapper valve, and that can move from the right to the left. And now instead of having a pulmonary embolism, or using the lungs to kind of filter out that clot, now that clot has access to the left side of the heart, which means then it can get sent out into your arterial system and cause things like strokes or thrombotic embolus and those type of things. Okay. So when you have somebody who has a stroke and they're not, a 60-something-year-old with carotid artery plaques, it's a 30-year-old female who's on birth control who has a stroke. Maybe think about this condition, and maybe this is the cause of that stroke. Okay. How do you diagnose it? Well, let's do an echo. But if we just did a normal echo, you may not see that right to left shunt because that pressure on the left is going to keep that valve closed. But let me do a bubble study where now I inject like agitated saline rapidly, and now I increase that pressure on the right side into the right atria, and now I got all these little bubbles of that agitated saline. It can then open up the patent foramen ovale, the flapper valve, and now you see those bubbles move over to the left. That's how we diagnose this. So if you ever see a bubble study attached to the echo, what you are specifically looking for is the presence of a patent foramen ovale. Because if we can diagnose it, especially in that female patient who had a stroke in their 30s, their 20s, we can do surgery to fix it, get rid of that flapper valve so that it doesn't happen again if they were to develop another clot down the road. Okay. So that's patent foramen ovale, not a true congenital disease, but kind of functions somewhat like an atrial septal defect. But let's move on now and move down into the heart, into the ventricular septum. And what happens if there's a hole in the ventricular septum? This is the most common congenital heart disease patient, or most common congenital heart disease that you're going to encounter. And fortunately, most of these will close by the time the patient is 2. I had a ventricular septal defect when I was born. I initially had problems gaining weight because of it. It closed on its own, and as you can tell, I definitely have not had problems gaining weight since. But it is so common that you can hear this. But fortunately, most commonly, these will close on their own without us having to do any kind of procedure to fix it. Okay? So there's a couple of different classifications on where it could occur, which is not really that important from a primary care standpoint. It's important if you're going to be the surgeon fixing it, if you need to, but you can see there's a couple of different places where this could develop. But imagine the consequence of having this defect. Left side, left ventricle has a much higher pressure than the right ventricle. So as the left ventricle starts to squeeze, you can imagine you're going to have that blood going from the left over to the right. And it leads to an acyanotic lesion because you're not having that deoxygenated blood going into the aorta and everything like that. Okay. So you're not going to see cyanosis in this disease. But what is happening is you have all that extra volume on the right side that shouldn't be there. You have all that extra pressure on the right side that shouldn't be there. And now the heart is going to have to compensate for that higher volume and that higher pressure. Well, what happens if that pulmonary artery pressure starts to increase, compensate, to the point where now that pressure is higher on the right than it is on the left. Flow goes from higher pressure to lower pressure, so it's now higher on the right than it is on the left, Now you're having deoxygenated blood moving over to the left-hand side, mixing with oxygenated blood, and getting then sent into the aorta and into the peripheral arterial system. And that reversal of that normal shunt is Eisenmenger syndrome, which we'll talk about in a couple of slides a little bit in more depth. But that is the concern, long-term concern for somebody with a persistent ventricular septal defect. So what are you going to see on your exam, or what are you going to appreciate on your exam that might make you suspicious for a ventricular septal defect? The classic description of this is going to be this harsh holosystolic murmur, best heard at the left lower sternal border. Okay? Left lower sternal border is your tricuspid auscultation site, right? And the reason it's best heard at this site is that flow of blood going from the left to the right is kind of hitting the wall, kind of adjacent or just inferior to the tricuspid valve. Okay? So that's why you hear this harsh holosystolic murmur better in that side compared to other auscultation sites. Okay. Other things you might feel, so you may have like a rumbling or whatever, but a harsh holosystolic murmur, that is kind of the clear descriptions that they use for it on your tests. Okay. If you have like a large VSD and you have a large shunting of blood over to the right side, then they're going to develop quickly right-sided heart failure symptoms, and you're going to see that present in the patient. So those are the physical exam findings to look for to be able to diagnose a VSD. Using our ancillary studies, what might we see? Well, chest x-ray, you may not see anything. If it's large enough, then you're going to see effects of heart failure on it, but we may not see really much of anything on a chest x-ray. So not a very good diagnostic tool for you. EKG, you may see some changes like atrial enlargements or ventricular hypertrophy is present. You may be wondering, well, why is it going to show a left atrial enlargement, left ventricular hypertrophy? And the reason for that is all that extra volume that's going over to the right, it goes to the lungs, and then all that extra volume comes back to the left. So now the left is having to deal with volumes and pressures even higher than what it should deal with. So now the left is going to have to compensate for it as well. So you may see that present there. But like ASDs, echocardiogram is going to be your test of choice because I can see the defect, I can measure the defect, and then I can also measure the flow and kind of get an estimation of how much is moving from right to left. And then I can look and see for any other consequences from that. Okay. How do we fix it? Fortunately, if it's small, it tends to heal on its own. We don't need to do anything about it. We just maybe need to watch them with repeat echoes. But if it's large, then we may need to do some surgical kind of fix to it. There are some other things like diuretics or whatever to help with that volume overload to kind of help temporarily fix or address some of the issues. But it's going to ultimately require a surgery to fix a large VSD. Okay. Let's go ahead and take 10 minutes, come back, and finish up. Oh, what's that?
Sure, Nottingham.
Oh, yeah.
Yeah, that's the best.
Yeah.
gonna crunch everything up, right?
She said, what are
Make sure it's the right one too. It's close to this building.
Like that. She was talking about hit all the arteries specifically. Like in all the places that
I like 2 seconds later, I'll get up. Yeah, it became
like too much work. Yeah, so somebody that graduated, like after the graduated, gave me his entire deck that he made. It was like pretty good. He's like, they don't change the slide. I take all this I think it was good for freshmen because it's just like a combination of like, and it's not like conceptual. It's much harder to like use algorithm to like conceptual, like be able to work through pathology. It's just like, what is this? Good for freshmen, not so great.
Every day.
I saw posting high motivation.
Uh-oh. That's what you were doing outside. You don't see it because the axis. Well, this to this. This wording is this.
Just to like, not.
And this is going to the space where our hands come out. What is it like doing like?
That's what I was hoping.
You do an arrow? Why? It's like this space where they come out. And then obviously the foramen is where the nerve root comes out of.
Good, paid off. And I'm not even and then like the last day or two, I was
Yeah, let me keep the degrees and so that's not fit for active duty.
we don't know how
From the heart, you know?
Like a line.
did that Grand Odyssey. He was bringing shit up that I told him about. So he says that in the movie that's his real reaction. He's
Cause it's like that space.
That's hilarious. That is a very because they were like the actual the written record.
I would point it more like
I can't do this. So he rewrote it. Yeah. Impromptu did that. You did go to Christmas?
I know.
Real good.
Honestly, all I hear is circle. It just said
I'm making their class.
Actually, no, I already answered this.
I was like pointing, and I was like, exactly
That's the real
Friday is like no study. I have to study.
Friday night pizza? Or EKG? Right after you No, it's real good. Real funny. Galaxy, that's how I think. That was my first time drinking it. You're seeing Galaxy Quest.
No. It's
So I was also thinking, Eric, if you're interested in you have a French press for your podcast, but you can just put it into a French press. That's what I do if it's on a special day. Just put it into the French press, cold water, let it steep, and then put it into it.
Why do you hate cold water?
I'm trying to
Like,
Oh, my doctor told me that as long as I'm not drinking freedom, I said it's like stabbing, I have to stop pulling
owl fly by, just
That's
take the
5. That's 10 cups of coffee.
It's not your time.
Well, I'm not reaching the green.
I was studying yesterday.
I
And
will
my
say-
wife was freaking out.
When you are fresh.
See the storm
Oh,
came
yeah,
up here.
it
What
would
do
be
you do down here? And you're like, oh, you know, something like that. Rather like stop halfway through. But I was around like a bunch of
I just had stuff for I timed it at 3 o'clock and I got eating.
oh, that's right.
His
Yeah, I'm not with that. Honestly, what I did was I just bought stuff like my normal grocery load for next week because like I'm probably going to go out and reading it. So then it's all like crazy stuff. No rest of the week. That's why you don't go and
All the fucking days.
He's with the
No, the 2 days that no one's at work. 7 days.
It's like spring, right?
Alright, sorry about that, the computer crashed on me. I was trying to get that figured out what the volume issue was, and I tried to get that video up and then it crashed, so, gotta love government. So we just talked about ventricular septal defects and how to treat them. And we talked about how, temporizing things that we can do to treat would be managing the fluid overload using like diuretics or salt restrictions and those types of things. We then wanted to talk about, so then we wanted to kind of talk about how do we, or what's the big concern about a ventricular septal defect? And that's the development of Eisenmeinger's syndrome, where now instead of that left to right shunt, where oxygenated blood is mixing with deoxygenated blood on the right side and having that acyanotic lesion, with time over, and this is not something like a week or 2 weeks, this is like years, decades later that this happens. The pressure on the right-hand side, because of all of that extra volume and pressure on the right, will cause a compensatory change, especially things like in the pulmonary arteries. Because the pulmonary arteries are going to be like, this is too much pressure. I'm having to work too hard to accommodate all this extra pressure, so let me make myself stronger. And you can see kind of in the graphic what happens. You get the circumferential adding of layers, and it really narrows the lumen of that artery to the point where now that pressure on the right-hand side increases higher than the left side, and now that blood is shunting from the right to the left. Now you have deoxygenated blood mixing with oxygenated blood on the left before it goes out through the aorta. Now that blood is hypoxic, which then leads to a cyanotic lesion. Which you can imagine, if this is going to take decades to develop, does it make sense that the best treatment for it is to prevent this from happening in the first place? Okay, if I can prevent that compensatory change, that circumferential narrowing of the pulmonary arterial lumen, if I can prevent that, then this condition doesn't develop in the first place. And the way I can prevent that is I diagnose those patients early on with a ventricular septal defect, and I fix it surgically if needed. Okay? Because what's going to happen, or how can you treat this if you don't catch it early and they develop this condition? You're kind of really, okay, maybe we can do some diuretics and stuff like that, and pulmonary vasodilators to help with the volume overload, and maybe opening up that lumen a little bit to allow more blood flow to go to the lungs for oxygenation and everything. But ultimately, the treatment would be a total lung transplant, because the entire vasculature of the lung is damaged from this condition. So imagine a total lung transplant, complications, how easy it is to get access to transplant lungs and all that kind of stuff. So the best treatment is diagnose these congenital lesions early before they develop this Eisenmenger complication. Okay. Now let's go on and talk about the patent ductus arteriosus. We talked about the ductus arteriosus is this bridge that goes from the pulmonary artery to bring blood directly to the aorta in utero or in the fetal circulation, right? Well, in about 1 in 2,500, maybe 1 in 5,000 births, this does not go away like it should. And it typically would be somebody who has has a premature birth or that maternal rubella. We talked about that being like the rubella syndrome, the maternal rubella syndrome. One of the aspects of it is a PDA. And the reason for this is what normally happens after birth is usually because of that increased oxygen tension that occurs now in the lungs compared to what was in the placenta, usually that then leads to a decreasing of the prostaglandin synthesis. So I decrease my prostaglandins, this thing closes up. But if I have somebody, a premature baby, where that prostaglandin synthesis remains high, to maintain that being open, then you're not going to have the signals there to close that shunt. So what ends up happening, if this doesn't close on its own, the pressure in the aorta is higher than the pressure in the pulmonary arteries, which is a reversal of what happens in fetal circulation. And what happens then is you have oxygenated blood going through this pathway, this ductus arteriosus, into the pulmonary arteries to become oxygenated again. Well, you can't oxygenate it again, it's already oxygenated. But all this volume that shouldn't be going into the pulmonary arteries ends up going into the pulmonary artery. And now it's having to work harder to move that extra volume and that extra pressure around. And when that happens, you have a volume overload or pressure overload that develops in the left-sided circulation, which then leads to left-sided heart failure. So now you're going to have pulmonary congestion developing and all those kind of things because all this extra volume, all this extra preload, this increase in afterload is there and really distorts the normal stroke volume, the normal cardiac output. But with all that extra volume going to now the pulmonary circulation, that could lead to pressures in the pulmonary circulation increasing, which kind of starts to sound like Eisenmenger syndrome. And what can happen is you can get a reversal of that shunt. So instead of oxygenated blood going from the aorta into the pulmonary artery, now that pressure is higher in the pulmonary artery compared to the aorta, and now that blood goes from the pulmonary artery into the aorta. And now you're having deoxygenated blood gaining access to the aorta. And when you look at somebody who has Eisenmenger syndrome due to a PDA, you're going to see a little difference in how they present. Okay? In Eisenmenger syndrome and ASD and VSD, you're having a kind of a total body cyanosis picture. But based on where this ductus arteriosus is located, what ends up happening in Eisenmenger syndrome from PDA is you have upper extremities in the head are getting all that oxygenated blood appropriately, but the lower body and the lower extremities are getting that hypoxic blood. So what ends up happening is you have normal color and everything like that in the upper body, but the lower body is cyanotic, just because of where that mixing occurs compared to a normal Eisenmenger's syndrome. So how do we treat it? Well, not how we treat it. What are we going to see? What are we going to hear? What are we going to appreciate on our physical exam for somebody who has a PDA? If they're small, they may be completely asymptomatic and have no idea it's there. If it's large, then they can start to display symptoms of poor feeding, heart failure, those types of things, and also breathing problems, because all that extra volume, all that extra pressure there in the lungs is going to lead to difficulties with breathing. On physical, the classic description of a PDA is this continuous machine-like murmur heard at the left upper sternal border. So over the pulmonic auscultation site, you're going to hear this continuous machine-like murmur. Continuous meaning both systole and diastole, you're hearing this murmur. Okay? EKG, because of all that extra volume that's there, you're going to see this left atrial enlargement, that's left ventricular hypertrophy. Chest X-ray, depending on how big it is, it may not be of diagnostic utility. But if it is large enough and it is compromising and causing heart failure, then you may start to see the symptoms of left-sided heart failure present on your chest X-ray. But again, low diagnostic yield. So echo is going to have to be your test of choice for this. And you're going to see a theme with congenital heart disease. Echo is always your test of choice if you have to choose anything for it. So how do you treat it? Well, you have a preterm infant who has a patent ductus arteriosus, then you can actually just give them an NSAID, like ibuprofen or indomethacin, and that will, with the medication, disrupt that prostaglandin synthesis, decrease that prostaglandin levels, to then cause a closure of the ductus arteriosus. So you're going to learn in pediatrics, you never give Motrin or any other NSAID until they're at least 6 to 12 months old, right? This is the one instance where you're giving a newborn an NSAID, okay? Because you're targeting the prostaglandins in this. And this is also one of the reasons we don't have women who are pregnant take Motrin. There's other things with placenta, but patent ductus arteriosus affecting the ductus arteriosus is another reason for why they cannot take an NSAID. If you have an older infant where that prostaglandin synthesis would have decreased on its own naturally, but they still have this patent ductus arteriosus, then that may need a surgical closure, which could be an open chest procedure where I'm going in and tying across that you see in the bottom part here. Or I can thread wires up through that ductus arteriosus and do things like heat ablation or place some coils that then cause an obstruction of that. So there's some minimally invasive kind of procedures that we can do to fix this. But there is the open chest procedure as well to close that. Then, like what we talked about in the infective endocarditis lecture, if they have a PDA, it's persistent, then they need endocarditis prophylaxis up until 6 months after it's repaired. Okay, once it's been 7 months past repair, then they don't need it anymore. Okay, let's then move on and talk about our last acyanotic congenital heart lesion, and that's coarctation of the aorta. We're going to talk more about coarctation of the aorta in our hypertension lecture, but we talk about it here because it is a congenital heart disease. So, by definition, coarctation of the aorta is a narrowing of the aorta. Usually it's about the same at the level of where that ductus arteriosus comes in. It's like a scar tissue band forms that causes a collapsing or narrowing of the lumen of the aorta. But what ends up happening, because you get that narrowing, is it will then increase turbulence and will also increase pressures in the upper body and into the aortic arch and everything like that. This is rare, but 1 in 6,000 births will experience this. So again, kind of going back to the example of Parkland Hospital having 12,000 births a year, 1 in 6,000 means at least 2 babies a year are going to be born at Parkland Hospital alone with this condition. And what's interesting is it can actually be associated with Turner syndrome, which is a 45XO, meaning that second sex chromosome is missing. And they only have the one sex chromosome, and that is Turner syndrome. So if somebody has Turner syndrome, they are at higher risk of having coarctation of the aorta. Okay? So there is a genetic predisposition to this. So with that narrowing occurring, the blood flow to the head and the upper extremities is preserved, it may actually even increase that pressure. So people may have like headaches and stuff like that related to coarctation of the aorta. But the blood flow to the lower extremities and to the lower body, the abdomen and stuff, is going to be impacted. So there may be some problems that are going to develop because maybe we're not getting the oxygenation that we need down to the legs and to the peripheral lower extremities. So what are we going to see? Well, if you have just a mild coarc, they may be asymptomatic. They may just have things like headaches or bloody noses and those kinds of things. But if it is severe, then they are going to have problems much sooner, and the symptoms are going to be much more severe related to this. And what you might see is the upper body is fine, but the lower body experiences cyanosis because you're not getting blood, or there's a difficult pathway to get blood down to the lower body. Now with that narrowing, especially if it's severe enough, what can happen is all that extra blood, or all that blood that should be going out in the lower body, is now going into the upper extremities. So you may start to see the blood pressures be higher. Kids, normally we don't think of as having hypertension. Unfortunately, we are seeing rising levels of hypertension in pediatrics because of childhood obesity. But typically, if you see a child or an adolescent with high blood pressure, be thinking coarctation of the aorta. Okay. And then the kind of the classic description of auscultatory findings for coarctation is going to be this infrascapular murmur. So if you see infrascapular, be thinking coarctation of the aorta. Okay. On our ancillary studies, what might we see? Well, all that extra pressure from trying to get blood circulating is going to translate back to the left side of the heart. So on an EKG, you may see left ventricular hypertrophy as a compensatory change, because now the left ventricle is trying to generate a higher pressure to get blood circulating out of it. So you may see that on your EKG. With chest x-ray, what you might see is this notching of the inferior surfaces of the posterior ribs, so rib notching. And the reason you get this is one of the ways you can get blood down to the lower body is by using the costal arteries to kind of go underneath the ribs and then down into the lower body. So you can kind of see that rib notching that you see here. Echo is going to be your test of choice because you're going to be able to see and visualize that coarctation of the aorta and measure how bad it is, what's the movement that is there, what's the flow across it, and all that kind of stuff. But ultimately, these folks would benefit from a MRI because I want to see how long is this coarctation. Is it just this little tiny area, or am I going to have to remove 3 inches of the aorta to get rid of the coarced portion of it? Okay, so the MRI is actually going to be important in helping with surgical planning. So how can we fix it? If we have a baby who is born with coarctation of the aorta, like we know they have coarctation of the aorta, one of the things we could do is actually give them prostaglandins to keep that ductus arteriosus open until we can figure out what we're going to do to fix that coarc. Okay, so now I'm having at least an offlet or an off valve to get rid of that pressure and extra volume that might otherwise go to the upper extremities. And then we can do surgery, which there's a couple of ways that you can do surgery. You can either do a balloon, kind of blow up that area, open up that lumen, especially if they're older folks. But if they're younger, then we can do basically just remove the portion that's affected and then suture it closed and go from there. So there's a couple of different ways to take care of coarctation of the aorta. And like any other coarctation, any other congenital heart disease, they need effective endocarditis prophylaxis if it's present and up to 6 months after it's corrected, okay? Now, one of the other things you gotta do with somebody who has coarctation is the concern is that they are now at a much higher risk of having like cranial aneurysms or intracranial aneurysms. So we need to look to see, do they have any of these aneurysms developing in the cranial arteries? And if they do, they are then at a much higher risk of having one of those rupture, and now you're having like a hemorrhagic stroke or even death from intracranial bleed. So you're going to have to do imaging of the brain every 10 years or so to make sure they're not developing that condition. Okay. Now, this isn't an exhaustive list of all the cyanotic congenital heart diseases. We're going to talk about a couple of these in other lectures, but we just covered the ones that were required by the PANCE blueprint. So don't think that this is an exhaustive list of all the congenital heart diseases, especially the acyanotic congenital heart diseases that you're going to see potentially. So. So let's go ahead and now transition from acyanotic lesions to now the cyanotic lesions. Does anybody know who the Olympian is here? Okay, Shaun White. American snowboarder, really kind of invented the competitive snowboarding field, especially in the Olympics, won every gold, everything like that initially. He was born with a congenital heart disease. He had tetralogy of Fallot. And you can see it did not hinder him being able to compete at such an elite level like he did. So the kids who we saw, I wish the volume had worked at the time, in the video, those were doomed to die within a year or so after birth. But based on our treatments now, because of things like Dr. Blaylock and Dr. Thomas, Vivian Thomas, we now have ways to fix this problem where now they can go and become Olympian, gold medal Olympians. Okay? They are able to now compete at a much higher level when 50 years ago they were doomed to die. Okay. So what exactly is tetralogy of Fallot? Well, if you know your Latin, tetra is 4. So that means there's 4 things wrong in tetralogy of Fallot. And ultimately, all 4 of these things are wrong, or all 4 of these things are present because of one problem. And that's this abnormal anterior encephalitis, and going towards the head, displacement of the infundibular portion of the interventricular septum. So this area here should be here. And it should be making this interventricular septum. But because that portion is kind of deviated anteriorly and up towards the head, I now develop 4 problems that cause this condition. The 4 problems are, okay, I've got a hole in my interventricular septum, so I have a ventricular septal defect, okay? I have a right ventricle outflow obstruction, so this narrows that outflow. So now blood's going to have a lot more difficulty getting into the pulmonary artery through the pulmonary valve, okay? Because of that ventricular septal defect and all that extra volume moving from the left to the right, my right ventricle has to work much harder, and I also have a much higher pressure I'm having to work against to kind of get blood through the pulmonic valve. That right ventricle is going to hypertrophy. So now you're going to have RVH associated with this. And then the other cause, or the other problem with tetralogy is now when the ventricle squeezes, path of least resistance is actually to go through that ventricular septal defect and go out to the aorta. And that's what contributes to the cyanosis that we see in patients with tetralogy of Fallot. So those four problems: hole in the ventricle, an outflow obstruction going through the right ventricular outflow, so that pulmonic valve, there's an obstruction. The right ventricle hypertrophies, and then blood is going, deoxygenated blood is going through the aorta. Okay. And that's what gives you the cyanosis. There's about 10% of congenital heart diseases, so about 5 in every 10,000 births you see this. It is the most common cyanotic heart disease, the defect. So of all the cyanotic congenital heart diseases, this is the most common. You can have some other things kind of associated with it. So you have a VSD. Well, let's say you also have an ASD, and now it's called pentalogy of Fallot, because now you have 5 problems going on with this. Okay. Tetralogy of Fallot does have a genetic predisposition, so DeGeorge syndrome, which is a deletion of chromosome 22 or microdeletion of chromosome 22, can put patients at a higher risk of having this congenital heart disease. So there is a genetic component to it. So what happens, what's the pathophysiology of having tetralogy of Fallot? So we talked about how you have deoxygenated blood because it has a resistance, higher resistance to flow out through the pulmonic valve and into the pulmonary arteries. And because of how that displacement of that fibular portion of the septum causes the path of least resistance for that blood flow to go, that deoxygenated blood flow to go through the aorta. And what can happen is anything that causes that pressure on the right to increase can precipitate a TET spell. So if I increase the pressure on the right, I increase that shunt of right to left, and now I get a TET spell, or I get a worsening of the cyanosis. So a TET spell is any time like they're crying or feeding, they become cyanotic. So in the video, you can hear the audio, and the mother is saying, well, how do I keep my baby from crying if I can't hold him? The reason we didn't want the baby to cry is because that crying increases that thoracic pressure, which increases that right-sided pressure, which then increases that shunting of right to left. So in addition to the cyanosis and the TET spells and all that kind of stuff, what else could you see? Well, you're going to have a systolic ejection murmur in the left upper sternal border that because of that outflow obstruction that we have is kind of mimicking a pulmonic stenosis. You may have a holosystolic murmur associated with that VSD also present. So a couple of kind of things there as products of the 4 things that are wrong in tetralogy of Fallot. EKG, okay, we already know that right ventricular hypertrophy is one of the criteria for tetralogy of Fallot. I can see that on my EKG. I can also see a right axis deviation. Chest x-ray tends to have this boot-shaped heart that you see here because of that right ventricle hypertrophy. Echo is going to be your test of choice because you're going to actually be able to see the 4 things wrong in this patient. So one of the things that could actually make that cyanosis better, and the video clip talks about it, where all these older kids were like to squat or bring their knees to their chest. What happens when they do that knee to chest or that squat is you're increasing afterload. And by increasing afterload on the left-hand side, you decrease that right to left shunt. Because now that pressure is higher in the left than it is in the right, And now, if you are having a shunt, it's that left oxygenated blood getting over to the right. So that's something they can do temporarily, and it just kind of adjusts the physiology that's present and can help with reducing the level of that cyanosis. Other things that they can do would be things like morphine or even like beta blockers to kind of relax the stenotic valve a little bit. But ultimately, these folks are going to need to get surgery to fix it. I can fix that ventricular septal defect. I can then fix a large portion or a large number of the 4 things that are going on with this condition. And you can see, if I do surgery, the mortality risk is actually pretty low. So I have a less than 3% surgical mortality if I do it, if I fix this as a child. If I wait until they're older, then yeah, the mortality rate does go up. But the 25-year survival rate after surgery is over 90%. That is how, and that is why somebody like Shaun White can get the surgery done and be an elite Olympian in his sport. So that's a pretty good odds of survival if we can do surgery early. Now there are some complications that we have to watch and monitor for and everything like that. We need to look for pulmonary issues, we need to look for right ventricular issues that may develop over time. But hopefully you will reverse the course of the disease progression once you have fixed the problem. That right ventricular hypertrophy should not continue to get worse once that side is not dealing with those elevated pressures. They are going to need annual EKGs because you do have that disruption of the conductive pathway, so we got to make sure they're not having arrhythmias developing. They may need to do like the continuous monitoring with like Holter monitor or Zio patch monitoring, just to make sure they're not having these intermittent arrhythmias if we don't catch it on an EKG. Questions on tetralogy?
Sir, why is the prophylaxis not recommended for this?
Why is it not recommended after it's repaired? So just because of the presence of tetralogy of flow, once it's repaired, it's not recommended. However, if there is foreign material that's present, like they had to put some kind of mesh in there or a metallic thing, then it will be, because now you have this additional thing. But most of the time what happens is when they fix it, the mesh that they might put in gets scarred up, and now it's protected, and now bacteria, your immune system, all that kind of stuff is not coming in contact with that mesh. Okay, so that's why about 6 months after repair, we don't need that. They're at a lower risk. But if we put in a metallic thing, like let's say as part of the process to fix this, we need to replace the pulmonic valve with an artificial valve, then now they meet the criteria for prophylaxis for that reason. So, yeah. Okay. That answer your question? All right, so let's now move on and talk about our last cyanotic congenital heart lesion that the PANCE requires you to know about, and that is transposition of the great arteries. Hopefully, these folks are not being diagnosed in your primary care clinic, okay? Hopefully, this is something that they diagnose before they are discharged from the hospital, okay? So, transposition of the great arteries is the pulmonic artery, pulmonary artery, comes off of the left side of the heart, so the left ventricle, and the aorta comes off of the right ventricle. In utero, this is not a problem, right? Because the right side of the heart is what has the oxygenated blood, or deals with oxygenated blood. So in utero, the baby may form and develop normally. But as soon as that baby is born, Now it's a problem because what happens is blood goes from right atria, right ventricle, aorta, through my arteries, back to the right side of the heart through the veins. It never goes to the lungs. Now flip to the left side, you have oxygenated blood coming from the lungs to the left atria, to the, deoxygenated blood coming up, and now it goes through the, pulmonic artery, gets oxygenated, it comes back to the left side of the heart, goes back up to the pulmonary system, comes back to the left side of the heart, and you just have this completely distinct circuit where now oxygenated blood is only going to the left side of the heart and to the lungs, and that's it. The right side of the heart, the deoxygenated blood, is being sent through this aorta because it's flipped, and now you just have that going through the aorta, that deoxygenated blood going through the aorta, going through the veins, coming back up to the right side. And you can see the problem that develops with these two distinct circuits. We're not octopuses, right? Where you have those multiple hearts that can handle this kind of stuff. And this becomes a problem early on in the life of the baby, especially as that patent ductus arteriosus closes. It's present in about 7% of congenital heart diseases, so 4 in every 10,000 births. So Parkland Hospital has maybe 4 to 5 of these born every year there. Okay. How it happens, basically, with the forming and the flipping and twisting and everything like that of the fetal heart early on, it's reversed. And now that aorta attaches to the right side of the heart, and that pulmonary artery attaches to the left side of the heart. And this can lead to severe hypoxemia, acidosis, which then can lead to death if it's not recognized and handled quick enough. And these babies are going to be blue quick. Okay. The TET spells, bringing the knees to the chest or squatting is not going to temporarily fix this problem. Okay. So what are you going to see in addition to the cyanosis? Well, in your ancillary studies, you may see a normal EKG because there's nothing wrong with the conductive pathway. Okay. But your chest x-ray, you may see this thing described as an egg on a string present there because those great vessels are coming off of the opposite sides of the heart. And then, of course, echo is going to be your test of choice for it because you can actually visualize the problem. So how do we fix this? Let's say the baby is born with this condition, but we don't have a pediatric cardiothoracic surgeon on staff there. We're going to have to transfer them 8 hours away by airplane to deal with this. Are they going to survive that? And the answer is probably not, right? So what we could do is let's prevent that ductus arteriosus from closing like it should. So instead of giving ibuprofen or indomethacin to drop my prostaglandins, to close the PDA, let's give them prostaglandins to keep it open. And that's what aloprostadil does, or a prostaglandin E1 infusion does. It keeps that ductus arteriosus open, so at least I'm having some kind of mixing of left and right circulation. Ultimately, they're going to need to get a surgery done, which it could be that I just take the 2 great vessels and I swap them. Or I could do this pretty complicated procedure that you see here where I specifically put this tube mesh-like structure in that will take blood coming from the inferior and superior vena cava and force it to go over to the left side so that it goes up into the pulmonary system and gets oxygenated. And then as part of this procedure, I then will direct that blood flow from the left atria to go over to the right atria, into the right ventricle, and up through the aorta. That's probably a little more complicated of a procedure than just swapping the great vessels on the heart itself, right? But those are the two things that can give you a definitive treatment for transposition of the great vessels. Okay. And again, there are lots of other congenital heart diseases that the PANCE does not require us to talk about. So if you ever see these in literature as you're reading or anything like that, please don't think that we have taught you everything that's out there, okay? It's just, this is the high yield stuff that the PANCE requires you to know. So, questions on this? And we are making progress now on our PANCE blueprint, so we're getting there. Questions? All right. I will be gone all next week. My